All right, good afternoon, everyone. So welcome to today's grand rounds. So thank you in advance for being attentive to the presenters and engage in the session, registering for CME credit for each session, completing and submitting a session eval form, muting your microphone once the presentation begins, and keeping your cameras on when appropriate. Next slide, please.
That was me, sorry.
It's okay. So here is the CME code for today. So I'll leave this up here for a little bit so you can all claim your credit. All right, next slide, please. And this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the grand rounds will address. Next slide, please. And now we have a brief introduction from Dr. Shi.
It's my great pleasure to introduce Dr. Botros-Brey, who comes from UT Health and Department of Urology. So Dr. Botros-Brey earned her BS biology from University of Dallas and her MD degree from UT Health Houston. So she did her residency in OBGYN at UT Health Houston. Afterwards, she completed a fellowship in urogynecology and pelvic reconstructive surgery at Northwestern University, concurrently with her clinical master's in clinical investigation, School of Public Health at Northwestern. So she has over 20 years of clinical practice experience and currently practices as a urogynecology at UT Health San Antonio in the Department of Urology, like I mentioned earlier. And she has served at the URPS, you might have to tell me what exactly the full name is, Fellowship Program Director at UT Health, a joint program between the Department of Urology and OBGYN. So her educational leadership spans in medical education continuum. She's a co-director for the Long School of Medicine, preclinical course Medicine, Behavioral and Society. And she has a faculty appointment with the Department of Medical Education, focuses on faculty. So she serves as the executive director for the Academy of Educational Scholars and is currently an assistant dean for faculty in the Long School of Medicine. So she has held several national and international leadership roles, published over 50 peer-reviewed manuscripts, is currently a fellow of the Executive Leadership in Academic Medicine program. Botros-Brey, a particular interest in teaching professionalism across the educational continuum, and her current research interest is focused on finding meaningful interventions to be able to address challenging learning environments. So Dr. Botros-Brey's presentations on professionalism as a competency. Thank you.
Thank you for that nice introduction, Dr. Shi. And I'm happy to talk to you guys, but I'm gonna say it's gonna be a little hard for us to have conversations if you're all, I'm looking at a black screen. Is that like the standard for these grand rounds? No? I'd love to see some faces. And that doesn't bother me if you're eating, but then I can get some feedback because I actually really love this topic, and thank you for inviting me to speak about it because it feels really squishy. So I want to kind of add some legs to it and give you some anchors to kind of think about, but also have fun with, like, it means a lot of different things to a lot of different people. It can invoke different feelings in different people. And so just kind of want to get a sense to you guys, just want to get a sense of how you guys think about it, feel about it, and kind of what some of the issues are that you struggle with. So I think at the outset, before I move forward, can you guys do like a waterfall in the chat, like what you're hoping to learn today? And I know this is grand rounds, but it's really hard for me to not be interactive at all, especially when I'm talking about this topic. So there might be a lot of uncomfortable silences. I'm just going to forewarn you. I'm also going to forewarn you that I am talking about professionalism, but I am by no means like, immune to professionalism lapses. And the only reason that I'm talking about this is because it's so squishy and there's so many different definitions, and I have an interest and I want to work to just try to demystify it or give us a common language. But I'm not coming to you from the like stance of I am the utmost professional and let me teach you what I know. Not at all. Okay. So some things in the chat. What are the expectations of professionalism at work? Okay. Brooklyn Anderson, things that aren't professional that we may not realize. I think that's important because sometimes you come to work and you're doing what you learned to do, not even realizing that some of those behaviors might be perceived as unprofessional by others. Absolutely. Any other thoughts about what you want to learn today? Okay, so my objectives for this talk, and hopefully what you guys will walk away with, is to recognize academic professionalism as a developmental process. So you guys are family community medicine. I'll go through, hopefully by the end of the talk, you'll have a sense of what I mean by developmental process. Think about how we can discern lapses in academic professionalism. So hopefully that'll address the things that aren't professional that we may not realize, and then discuss strategies for addressing those lapses. And then you wanted to talk about generational differences in perceptions of professionalism. That's a tough one, I'm going to have to say, and I think not my area of expertise, but I'd love to open it up for discussion. Hopefully we can create enough of a safe space to be able to have these conversations. Okay, so again, waterfall, speak up if you're comfortable, but how do we define professionalism? And I'm putting up a picture of Dr. Osler because someone recently said to me, when you talk about professionalism, what is it that you talk about? Because where I'm from, it was really instilled in us like Oslerian professionalism, which, the physician, with the bow tie and like kind of a persona that might feel outdated. And so I'm just wondering, like, when we say that word, what does it invoke? And there's a quote here that I like from Dr. Osler that says, the good physician treats the disease, the great physician treats the patient who has the disease. But what do you guys think? So throw some things at me in the chat. How do you define it? Or what do you think it should, how do you think people define it? Or what are, so how do you define it? What do you, how do people define it? Maybe what don't you like about the definition? Anything you want to throw in. So respect. Okay, I love that. Being dependable. Okay, I like that too.
When I think about it, maybe this is an aspect that we could talk about more because maybe it fits into what you were talking about, where it's like an older standard of professionalism, but like a certain level of being less colloquial with your language, and using a certain level of professional language, I guess, to I'm not sure what the best word would be to describe that, but
so kind of if I'm understanding you correctly, and please like correct me, but the idea that like there's a formality maybe that comes with professionalism versus like a casualness.
Yes,
okay.
I think that's a good way to point to.
And you're advocating for that formality or away from it?
I'm not sure. I was hoping you would bring more light to it, I guess. I think a certain level of formality is indicated, I think, but maybe not as much as what you were describing as being taught to people in the past. I think we've seen that certain level of like colloquialism and like warmth is a big part of treating patients. So
Yeah, I would, yeah, I think I lean towards the latter, kind of that more casual is okay and fair. Probably that's just how I practice, but okay, any other thoughts? Treat the person, patient as an individual. I like that. So I think respect is a big part of professionalism. We can delve into that a little bit deeper, being dependable. So that's a little bit of a you know, again, it's a term, and how do you determine if somebody's dependable, but like rely on behaviors and treating the person. So a lot of these that you guys are bringing up relate to how we show up, how we behave, how we treat the other person. And I think that's an important thing to think about. Okay, so the ABIM Foundation has the physician charter, and they recently, not recently, probably in the past, you know, early century, early 2000s, came up with some principles and talked about the primacy of patient welfare as like one principle, patient autonomy as another, and social justice as like a third. And so you go forward, and in that definition, professional responsibilities are a commitment to competence, honesty with patients, patient confidentiality, maintaining appropriate relation with patients, improving quality of care, improving access to care, just distribution of finite resources, scientific knowledge, maintaining trust by managing conflicts of interest, and then commitment to professional responsibilities. So pretty comprehensive list, I would say, but I'm going to ask you, and it actually just occurred to me when I was looking at this list, that something's missing. Can any of you pick it out? And, you know, don't worry if you can't, but I just wonder if it's obvious to anybody, because it took me a long time to kind of notice it or pay attention to it. Any thoughts?
Well, equity, like treating patients not based on what their backgrounds are.
I think just distribution of finite resources probably fits that. I think this is a little bit of like, what am I thinking? So I'll just go ahead and tell you what I'm thinking. It's, as it should be, very focused on the relationship with the patient. Correct? Yeah. Okay. And so if we're only focused on the relationship with the patient, what are we missing?
Oh, among your own colleagues.
Relationship with the others. And where do you guys see or feel most of the professionalism lapses?
Among your own treatment teams, your colleagues.
Yeah, I would agree. So, oh, look, and I missed it on the chat. So treat the commitment to our own self-care. Yeah, certainly. Altruism becomes a big leg here, and almost to the point of burnout. And I always I'm careful when I talk about this, because we have to be altruistic in medicine. We can't do this job if we're not, but not to the detriment of ourselves, which is the way that the field has moved us. Cultural backgrounds. Yeah, I do think that just distribution is trying to bring that in. And then, yeah, with our colleagues. Yeah, thank you, Dr. Obride. So let's move forward. So I actually like, this is an old definition from Stern early on that I feel like encompasses a nice idea of professionalism that allows for flexibility. Okay, so one of the things that is challenging, right, is holding someone accountable when they're not doing something the right way, right? So as program directors, as leaders, looking at your colleagues, it works when your colleagues or you have a competence in what they're doing, right? And that is the base of our professionalism, right? So we are a profession of doctors. Without being competent physicians, we can't be professional. I'm sorry, I'm not sure. We can't be professional. So first and foremost in our training, in our practice, is to be competent in our chosen trade and craft, okay? And so when someone tries to, in your residency, teach you and make you better, we're working towards competence. And like we know that in those competencies pieces, we've got medical knowledge as a competency, we've got skills, clinical skills as a competency, right? So those are explicitly brought out as things that we're trying to work on, and that's what we all try to do. However, I would say sometimes it breaks down in this area. If someone is not competent, we often don't know how to hold people accountable. So that's like one area to think about with regards to professionalism and lapses. Look at the second bar, communication skills. So I think initially when I saw this, I was very focused on the excellence, humanism, accountability, altruism part when I first started looking at professionalism. The more and more and more I do this, the more I see the wisdom in that competence being the base and communication skills being number two. So we kind of alluded to that often the professionalism lapses that we encounter happen to be with our own colleagues. And I would posit a lot of that has to do with communication and communication skills. And so if we wanted to work on something to improve our professionalism, working on understanding and communication would be could be a really big part of that. I'm going to skip over ethical and legal understanding because I think we actually do that well. We talk about conflict of interest. We have like a whole team that works on compliance. We have like an ethics team that you would call at the hospital. So I feel like we actually have that bit covered more so than the others. And then excellence, humanism, accountability, and altruism. I don't think we would argue with any of those, but they all have like their what is it, the bright side and the dark side, right? Too much excellence could lead to perfectionism, which in and of itself might lead to problems or issues. Too much altruism might lead to burnout, right? Too much accountability might make it hard for anyone to do anything if you're always looking behind your back because someone's like trying to hold you accountable for something. Like there's no flexibility or room there. Although I don't know what the dark side of too much humanism is. Maybe there, like if you're too empathetic, it's too hard to do your job, right? But if you don't have humanism, if you're not excellent, you're not accountable, you're not altruism, what are you doing here as a physician, right? So I think that this definition to me is really flexible and we can work on it. We can like work with it. Okay, so just for shared understanding, I'd like to use this definition of professionalism moving forward. Okay, so I'm going to give you a case, and so we'll just jump right in. Dr. Farmer is a third-year fellow who is on call for the ICU. He is contacted by one of the senior surgical residents, Dr. Hussein, and asked to accept a transfer from one of the general surgical services. The patient in question was admitted today for a revision of a dialysis shunt, but had an episode of hypotension that was prolonged and took a long time to respond to treatment. Dr. Hussein felt that the patient needed intensive care. The fellow flatly refused to accept the patient and directed the resident to admit the patient to the regular ward, stating he didn't have room on his service for every dying dialysis patient. Okay, so I'd like to move you guys into breakout rooms. I think we have 7 rooms, but that might be too many for this group. So what do we have?
I have 5 rooms right now already.
5 rooms would be great. Let's do it. Perfect. Okay, is my screen still sharing for you all, or do I need to reshare?
Please reshare.
Okay, so I think we might have had a little bit of a technical issue. Did you guys have a chance to talk about the case? And I realized that you didn't have the actual questions to go through. So let's see if we can, based on your conversations, if we can answer these questions on my screen. So now that you've had a chance to kind of talk and get your thoughts out, can you share with us what stands out about the fellow's behavior? You guys can put it in the chat if that's easier. We just chatted not about the case. Thanks, Stacy. Okay.
About professionalism,
Um,
though, but we just were talking in general.
Okay. Do you want to share anything, any insights that you guys came up with?
I had the family medicine residents with me, and the thing that we had talked about, I was asking them, what was your exposure to just professionalism in general in terms of teaching, learning, and everybody basically said it was on the fly during clerkship, nothing intentional, and that they wish they would have had like OSCEs dedicated to that, to actually have dedicated time to talk it through with common scenarios that they would see in the clinical settings. That's what we were chatting about.
Okay. Yeah, I think we have, like, those of you that went to UT, we do have, like, I lead that course, the Professionalism in Society, and there's so much to cover just in that time frame, but we do try to cover some of those scenarios. Yeah, but that curriculum is not standard across the nation for sure. But here I think, you know, we could standardize it, or we can, you know, each program can take what they want and do with it. So, okay, anyone have thoughts on what stands out about the fellow's behavior?
Dr. London's gonna speak for our group.
Okay.
sure. So, what we were thinking is that like this is a behavior that shows a lack of humanism and, of course, like a lack of professionalism. We said that, for example, the attending never listened even to the story. He just went through and said, like, this is a dialysis person like every other dialysis patient that is gonna die, not even took the time to listen. We were discussing that this type of behavior, sometimes we learn that even without knowing that, like subconsciously we become the attendings that are our mentors, and that might be very dangerous. Like we see that as students or as residents, and we see, oh, this attending is kind of rude or is not that empathetic, and we can like identify that behavior, and after a couple of years or a couple of months we become that without even noticing. And then lastly, we said that this is a situation that might happen. And we also saw that one of the last names of the case is like not the typical Anglo kind of last name. So we were exploring the idea about like if that has to do with the case, if there is like some kind of bias around those like when we are working as IMGs in the medical field.
You guys bring up so many points. I love doing this because every time I go with a different group, like people bring out different things in the case. Yeah. You know, it may be, you know, and the difficulty that IMGs have in medicine and residency, it has actually been documented, and it is a real struggle, and there's a difficulty, like they're, you know, definitely a group that we need to pay attention to. I also think it's to try to not always have the typical Anglo-white name there so people can identify with characters. So I think it's a little bit of both. But I love the point about we initially recognize it and then over time might become that. Okay, so there's many things to that, one of which is role modeling. And so I often ask the question, do you guys view yourselves as role models? And if the answer is no, I understand that, but I will also tell you that regardless of whether you want to be a role model or not, you are. And so does that make you think differently about your behaviors and your actions? And then the second thing is what you're talking about is the hidden curriculum, right? You become, there might be a curriculum that you're taught, and then you go into the real world, quote unquote, and you're like, well, this is just how it's done, or this is how this person is surviving. But I would even argue there's a systems issue here, because why do good people that have come into medicine, right, to care for others behave and act this way, right? So I think that once you start realizing it's layered, you have more empathy, and then you can start working through it. Because what's the knee-jerk response? Like, if we didn't take time to have our discussion, what's the knee-jerk response? That fellow was rude, right? That fellow, right? And we start blaming people instead of like really digging deep and finding situations. So I think there's many layers to this. And I will tell you, it's a really like big and broad topic, and we may not get all the answers today, but I hope I can raise some questions in your mind that might change the way you teach professionalism, or might change the way that you think of yourselves on the wards with regards to being role models, being more intentional about that. Okay, so let's move on. I think the two questions, can professionalism be taught? In our group, we came to the understanding that it could be taught. And I think that that's an important distinction to make, because if you don't think it can be taught, then we go through life in medicine kind of the way, with this underlying thought that you're either professional until you're not. And so then you have a professionalism lapse, I'll call it, and then you're labeled unprofessional, and it's really hard to come back from that, right? But who of you has never had a professionalism lapse? I can't, I have multiple lapses all the time. So how can I kind of assume that everyone else is going to be perfect? And so I think it's, kind of flipping the script a little bit and saying, okay, we all have lapses. And it doesn't mean that we're not professional people, and how can we navigate this? So if we go through that, the old paradigm is it's a character trait, you are, you're not, you're unprofessional, and then your response becomes punitive. But in the new paradigm, it's a competency, just like everything else. So I will point out to you that the ACGME has 6 competencies in residency. Professionalism is one of them. Like it's got its own competency. So it can be developed. Like, you are in family medicine to learn how to behave and act like family medicine professionals, like above and beyond physicians, right? So each specialty has their own professionalism traits. And if you believe it can be developed, then you view lapses as just that, just like you wouldn't expect a first-year resident to know what a third-year resident does. And so you're going to expect them to have questions and gaps in their medical knowledge, and you're not going to yell at them for not knowing. You're going to teach them, right? So it's the same thing with professionalism. So that's what we mean by developmental. So a professionalism challenge is a situation that might make it difficult for an individual physician or physician in training to remain true to their professionalism values. And a lapse is an error in judgment, skill, or attitude that leads an otherwise competent physician or physician in training to behave in a manner contrary to established professionalism norms. So I'm going to ask you about that case. Do you think that fellow had a lapse, or do you think it was a professionalism challenge? Or do you think it could be a combination?
Probably combination.
Okay, tell me more.
Just because I think, well, I mean, you can't really assume, like, I don't know how he is in other situations. Like, this was just one situation, so maybe this is like the only time he's ever responded to a consult like in this way. And maybe also there's like outside challenges, like the ICU like really is full, and he's overworked and a shift, or those kinds of things that are in other situations he wouldn't respond this way. So it could be, a lapse, or these challenges. Just kind of need a little bit more context or timeline.
Yeah, I like that. So I think this is what I'm hoping to do, is to get you guys to start thinking outside of like the initial gut reaction of that fellow's unprofessional to, okay, well, clearly he had a lapse, but what else could be going on? Could there be a challenge here that was making it hard for him to behave in a way that he felt or she felt could hold their values? Okay, so I'm going to move through this a little bit quickly. I think we made the point that it's a competency, and so we're growing in our competency. But there are influences of context on your professional behavior, right? So when we think of those competencies and milestones, a novice would be like what we're doing right now, right? We are talking and we have all the time in the world. We don't really, but we're free from like distraction and patient cares. And so we can actually like think and talk about this. So that would be like me in that medical school class. Competent would be when I can actually show you that I can maintain that professional behavior, but also there's an unmet deficit, or there might be a patient conflict or values conflict. So this is like now we're on the world, we're clinical, there's a stressor, but I'm able to maintain my professionalism. Proficient is we're going to add a time pressure to that. An expert is now you're going to put me in a new situation. And I think in our group, one of the points that came out is, the first time you encounter something, you might not encounter it well. You might not deal with it well. And so it's something that you can teach, and it's a learned behavior over time. So if we're expert, even given a new situation, we can maintain that professionalism. So just
I
to
have
give
a question about that, Dr. Botros-Brey.
Yeah.
How would you, and maybe I'm just not thinking about it, or am I thinking differently about it? A person's, because like kind of what you framed, that we've all have lapses, we all will have lapses, we're human. How might you view someone and their level of competency of when there is a lapse, that they actively take the steps to resolve it?
I think that would, yeah, I think that's kind of an let's go back. It doesn't discuss that here. But I would see that as definitely a proficient or expert move. I think it's really hard for people to admit when they're wrong. But I would say that in that role modeling, that's really important, right? So we talk about being intentional about role modeling. And so sometimes you want to role model how you resolve a difficult situation, right? So sometimes I go in, I run late in my clinic, and it's because I want to give my patients, I really want to understand, and sometimes that takes time. But every once in a while, I run into really anxious patients that ask me lots and lots of questions. But by the time I realize that I'm dealing with an anxious patient, my patience has already run thin. And so then when I start signaling that I need to go and they keep asking, like I have a really hard time. And then sometimes I lose my patience with the patient, right? I'm sharing with you like a not so great aspect of my clinical care, right? So I know, okay, now I'm actively working on that, but I have fellows that train with me, right? So I could do one of two things. I could just go in and walk out of the room and be like, that patient, oh my God, I'm so frustrated by them, and move on, right? What else could I do?
I think like it says on the slide, sometimes reasoning, maybe thinking like that patient, but sometimes like we think like what went through their day or what happened, and kind of tried, now that we step out, kind of come to our senses and see another point that we might handle it better the next time.
Yeah, exactly. I'm a human too, right? Like, so that doesn't mean I'm never going to have lapses, but now I can say to the fellow, wow, you know what? I really shouldn't have like lost my cool in there. And I'm sorry that you witnessed that. And I'm going to try to do better next time. And maybe I'll explain why, and that I'm actively working on it. And it might be something that in clinic we're working on together, but that's the role modeling, right? So, it's not to say that you have to be perfect all the time, but it's to say, I recognize that I didn't do this well. So let's talk about what we could do better next time. Because then you're modeling humility, and you're modeling problem solving, and you're modeling like your own learning, right? And all those are good things to model. Because if we only model that we're perfect, what are we doing to our learners? Does that make sense? Yeah. Does that answer your question, Dr. Irvine? Okay.
Yes, it is.
Okay, so these are just like visual images of like what competent would be. And here are some of the core competencies. You know, now these words, like this was like competency 1.0 and so overwhelming. Passion, integrity, respect, responsive to patient needs. It's almost like they took each of those pillars and like made the whole pillar like, you know, level 1, 2, 3, 4. And I think rightly so, a lot of people didn't like jump in and create professionalism curriculum. This is like really hard. But then you get to milestones 2.0 and they start to make a little more sense. Demonstrates behavior in routine situations. Okay, we can monitor that, right? Level 3 demonstrates a pattern of professional behavior in complex or stressful situations. We can monitor that, right? And then this gives you language to hold people accountable to, right? So if someone is routinely losing their cool, like you could say, hey, you know, this is one of our competencies. So let me sit down and talk with you about potentially what's going on here. And then here's a competency that deals, you know, a milestone that deals with well-being. So what I like about this is that it actually gives you language when you're, you know, wanting to think about it. It puts words to those behaviors, and then it gives you a framework to start talking to people about holding people accountable. Now, this is also work that you and your CCC can do. Like, what is our standard of professionalism? What are the things that we need to call to each other's attention? If I see someone doing X, that's like a never behavior. We need to have a conversation with that person, right? Versus, yeah, okay, like that one we can let slide a little bit of time. And those types of conversations are really dependent on each context, right? Because what surgeons might view as like, you know, high priority may not be high priority in family medicine due to time pressures, right? Like we have the whole OR and the way that that's run, that might be a little different than when you're working out in the community, right? So are you starting to see, like, I think what happens is we go to like tangible behaviors, like you're late, you didn't turn in your documentation on time, which those are important things, but are you going to define an entire individual by professionalism by if they do their paperwork on time or not? But we often default to that because it's easy, like it's tangible, right? Does that make sense? Okay, so factors that affect your behavior, self-intent, self-efficacy. We talked about that role modeling. That's really important. What if you're burnt out? What if you've only had, you know, what if you've had more negative role models than positive? What if you just like life is stress and we're short-staffed and we're remediating 2 residents and like that's the situation that we're in, right? And then you can start to understand that there's more to it than, you know, the individual who's not being professional. So I'm going to reread the case to you. And like, given what we've said, I want you to kind of rethink about this case with some of these other factors. So Dr. Farmer is a 3rd-year fellow on call for the ICU. He's contacted by one of the senior surgical residents when he's asked to accept a transfer from one of the general surgical services. The patient in question was admitted for the revision of a dialysis shunt, but had an episode of hypotension that was prolonged and took a long time to respond. Dr. Hussein felt that the patient needed intensive care. The fellow flatly refused to accept the patient and directed the resident to admit the patient to the regular ward, stating he didn't have room on his service for every dying dialysis patient. Okay, so can we do, instead of a breakout, do you guys mind just telling me what you think now triggers for this unbehavioral professional could be?
The fellow could be overworked. We don't know how long. If he violated 2 hours, he has a lot of things going on outside work. That might be a personal trigger.
Could be personal. Yep, a couple of you put in burnout for sure.
Yeah,
One
the
thing is
ICU is
also-
probably pretty full. Yeah.
Okay, so that could be an organizational or even situational thing, right? That the ICU really is full and he's got to prioritize. Okay, what else?
It might also be the culture in ICU. Like there's some residencies or like programs, I don't know, or like areas in the hospital that is the culture. Everyone talks like that, everyone is like that, and you get on the same system when you are rotating or doing or being part of the group.
Yeah, I love your insight, because one of the other areas that I like to explore is mistreatment. And often the biggest factor that predicts it is the culture. Because those are the unsaid behaviors day to day. It's just the way of being. And most people kind of follow along, like it's uncontested, right? So you really have to think about that culture. Okay, so here are some triggers. Is there anything on this list that surprises you that you would change, that you would add? Can you guys see it? Does anyone need me to read it to them?
I think so I had one thought in terms of like clinical disagreement. So let's say just in a situation of wanting to upgrade a patient from the floor or even admitting a patient from the ER, and we run into this, is something that would just, I think, is a professional courtesy and also just proper medical management, is for the provider who's being called, like the ICU, rather before they say, because on the surface or per chart review, it may look like, no, this patient doesn't need to be in the ICU. Like, I disagree. But to ask that provider who's calling, ask like, okay, what are your reasons that you think that they need to intensive care? Or what are your reasons you think they need to be admitted, before giving your opinion that they don't need to be?
Yeah, that's so interesting. Do you feel like that would help with the decision making, but also the person feeling heard rather than dismissed?
Yes, to where they at least know, like, okay, they heard, what I was thinking, and then they just disagree, and then maybe like, okay, well, at least like they heard what I was saying, and I trust their judgment.
Yeah,
Um,
like it gives you a sense of like security
mhm,
too, that they're not missing, like you're wanting to take good patient care. Yeah, I think that's true.
Yeah, and I think that's partly like respect, is within that, and just, I mean, it's just correct in terms of like medical management.
Mhm. Yeah, I think what you're describing is good communication, right?
For the factors on this slide, can you talk a little bit about culture that rewards bad behavior?
Yeah, what do you think that means?
Like maybe you get home earlier for some reason, or like if you're shorter with people,
Oh,
or things
interesting.
that are most convenient for you and your schedule. Like if the structure is not conducive to preventing burnout, that's kind of the things I think of.
Yeah.
But
That kind of made me think, like, say like the ICU team is like, yeah, you blocked that transfer.
Yeah. Yeah, I think that latter one, I am curious what you're intending. Sorry, I think I'm not quite getting your point, Ray.
I was just wondering if you could talk more about how that would contribute, or what's meant by the culture that rewards bad behavior.
I think it's that, like what Brooklyn said. Like it's those sorts of things end up being perpetuated and the reward is that they had the outcome that they wanted and no one held them accountable, right? I think cultures that reward bad behavior are cultures that are poor in holding people accountable. Okay, so this is a framework that I don't think is unique to me, but it just helps me think about it. And I am looking for theoretical frameworks that might include this. And I think there's like some out there, but I'll tell you, just after doing this talk for a while now and trying to communicate it, this seems to be kind of the most consistent way that I can communicate thinking about targeting or interventions. Okay, so the I is the individual, right? So I come to the table with my own personality, with my own culture, with my own identity, with my own communication style, with my own ways of conflict, just my own way of seeing the world, right? I am not perfect, right? And so there are things that I can work on. I can work on my emotional intelligence. I can work on my communication. I can work on discipline, like 10 million things I can work on, right? Now, it's better if I'm self-reflective and try to identify those things and work on them. But a lot of the wellness initiatives focus on the I and may or may not be targeted to the individual. Like we may not all need resilience training. Some of us need communication. Some of us need conflict, but certainly one size doesn't fit all, right? So trying to identify or match to the individual what would help them thrive in their situation, right? Now, I'm going to have interactions with people on my team. So the arrows are going to be interpersonal. And there's going to be multiple interactions. And some of them are going to be positive and some of them are not going to be so positive, right? So those interactions are another point of potential targeted intervention. Communication skills, active listening, conflict management, right? So the relationship between individuals is another area that you can target intervention. Then we have a team, okay? So the I's, and those interactions make up the team, but then the team itself has some like rules of engagement. How many of you, when you get on your teams, have a structure to your team versus you just get on the team and start doing the work? And in that scenario, which works better?
Definitely works the best if we know our roles in the team.
Yeah.
Right.
Yeah. I mean, every time I ask the question, think back to a team that worked well, good leader, good communication, we all knew roles, and then what about a team that didn't work well? Well, those things weren't present. Yet, how many times are you on that good team that is clarifying those things? Like, it's very interesting. So like, we know what to do, but it's in the implementation. So I'm not telling you anything new or that's not out there. It's just, it's all intertwined. And one thing isn't going to fix all of it, right? So those of you that are chief residents or faculty of teams, on day one, you can make sure that your team has set their expectations and roles. And some of that might be mentoring the chiefs on the team to do that, right? But that's one change that could be super intentional that could make a big difference for your culture, right? Now, what is culture? It's these interactions played over and over again every day, okay? So if our culture, and I'm like in 3 different departments and I see the 3 different, I see various different cultures, but let's say we have a hard time holding people accountable. Okay, then what happens? X person did something wrong. Do we go talk to X person or do we talk to Y person about what X person did wrong? And then does X person hear from like Y person the complaint? Is that psychologically safe? Is that helping anyone? So we've turned like something that we need to address into gossip and potentially marginalizing that individual, right? We're not intentionally doing that, but we do, like it happens, right? And so back to clear communication, intentionality, clear roles, holding people accountable. So having direct conversations, lifting them up. And we're just, a lot of us didn't train that way in medicine. And so it's like it's a new way to think about it. I don't know the culture of family medicine. I find my perception is that you guys are really respectful of each other, and it may be like in working with some of your colleagues. But amongst yourselves, these are things that you can certainly take care of. Then you get to the clinical learning environment, then you get to the system. Now, me as an individual, I might not be able to affect the system. So instead of venting about the system, like turning inward and saying, well, what can I do? What's in my power, right? My own actions, my interactions with others, and maybe my role on the team. Those are all things that I have influence over, right? So again, shifting from things that are the system's broken to well, what can I control? And then who can I talk to that might be able to control the system? Like, does your program director have influence over the ICU bed count? Does your chair have influence over the ICU bed count, right? So those sorts of things are where we can start targeting intervention. So here's just like examples of like, at the individual level, there's that, I can't change your identity. I can't change your personality. I can't change your values, but we can work on resilience, your coping ability, your emotional intelligence. We can work on work styles. Do we have a shared mental model that's making it easier for us to work together? How are we addressing conflict? Is our communication poor? How are we holding each other accountable? And then team. So I spend a lot of time in the 2 I's and the T, because once you get to the CLE and the organization, it's a little bit harder at the individual to target. Does this make sense to you all? Yeah. Does this give you like some framing for like where to kind of start thinking about making changes if you want to? Yeah. Okay. Okay, so normally, so I think we're like 3 minutes over. I feel like we should just end here. Is this, because the rest of it I can is like a stepped approach to intervention, but you have access to this on the Kern National Network. So I can send you guys this video, but it's just a quick like, okay, how do I hold someone accountable? How do I have that conversation? And there's like a video vignette that will go through that with you guys. So, and then that's the end of the talk. Do you guys have any thoughts, questions, concerns?
Quick question about the team intervention. I guess is the responsibility of the judgment or identifying the lapse fall on the leader, or I mean, I'm assuming everyone should be self-reflective and then be open to giving each other feedback. I wonder if you have tips on how to work in a team environment.
Yeah, I think like setting up your expectations at the beginning, I think is really important. And you can, as a team, say, what are the expectations for the team? And if someone's not meeting that expectation, how are we going to help? Like, are we going to, bring that individual to the leader? Are we going to help that individual that day? Like, is it a team and we're all going to get the work done? And one day you might be tired and the next day I might be tired, but collectively we're going to bring that up. Or do we have our individual roles? And so I think there's a lot of, I think each team with its own personality can decide. I think the point is to have those intentional conversations. Now, if you're witnessing someone that's truly struggling, you need to have those conversations with maybe the team lead or the program director, who can then go back and have conversations. Like it's always good to try to have those direct conversations, and feedback is a way to do that, right? So learning how to give feedback is really helpful in these situations. So, hey, I noticed you didn't get the labs today, and that was really important for the team. Can you help me understand what happened? 3 days later, they're still not getting the labs, and you've talked to them. Okay, now you got to talk to the team lead. Okay, team lead talks, they're still not getting them. Now you got to bring the program director, right? Instead of, sometimes I think the other residents just cover and get the work done, and then they are upset because they've got the workload, and then they start venting and gossiping, and then it just doesn't get addressed, right? So I don't know if that's helpful, or if that's what you're asking you.
Yes.
You're very welcome.
Thank you. Thank you so much. This is so helpful. And Catherine will probably, or I can share the slides. We can go over some additional materials.
Perfect. Yeah. All right. Take care.
Thank you.